Good evening or good afternoon, everybody. I am Keith Sterling, interventional radiologist and senior medical director for the vascular division at Boston Scientific. I am thrilled to be moderating this webinar this evening on HI-PEITHO clinical trial results and implications to patient care. We have an amazing faculty that I will introduce in 1 second. We are just coming out this past weekend from the ACC meeting in New Orleans, where we had an amazing, actually the first late-breaking clinical trial that was presented at the meeting on Saturday morning, March 28th, 2026, kind of the day I think that PE treatment potentially will change. And it was very well received. Everybody is super excited about it, and we're here this evening to talk to you about it. So let me introduce our faculty. We have Dr. Sofia Nadanov, Pulmonary Critical Care from Washington University in St. Louis, Dr. Greg Piazza from Brigham and Women's Hospital, Dr. Ken Rosenfield from Mass General, Dr. Peter Monteleone, interventional cardiologist from Austin, Texas, and Dr. Michael Young, interventional cardiologist from Dartmouth in New Hampshire. We have a lot to cover tonight on this super exciting trial, which I think everybody's been hearing about for several years, certainly if you're paying attention to the PE space, a trial that started enrolling in 2021, so kind of early COVID, quite honestly, and was just now presented and simultaneously published on Saturday in the New England Journal of Medicine. So really, without further ado, I want to get started, and Mike Young is going to basically run through the trial for everybody this evening. Michael.
Great. Thanks, Keith. And thanks to the other panelists and all the attendees who are listening on the call on behalf of the investigators for the HI-PEITHO trial. Very honored to present the results of this late-breaking study. This is the ultrasound facilitated catheter-directed thrombolysis versus anticoagulation alone for acute intermediate risk PE. Next slide. So we know from the PEITHO trial, which is now over 10 years in the making, that the use or efficacy of tenecteplase versus placebo for intermediate risk PE is effective in terms of the endpoints of all-cause mortality or hemodynamic collapse. However, that does come at a cost, and that cost is increased risk of intracranial hemorrhage, specifically hemorrhagic stroke. Next slide. So these are the guidelines that were recently published by the ACC and AHA. Greg Piazza, who's on this panel, can talk to you a little bit more about the clinical severity scores here, as he was the primary architect of this scoring system. But as you can see, even in the most current guidelines, the role for advanced therapies, whether it's systemic lysis or advanced catheter-directed therapies, have been very heterogeneous, has demonstrated a lot of heterogeneity. And most receive either 2B or at most 2A class of recommendation. Next slide. So this created the foundation for the HI-PEITHO trial. And this was a multinational, multi-center adaptive design study, randomizing over 500 patients from 59 sites across the United States and Europe to either catheter-directed thrombolysis with the ECOS endovascular system with anticoagulation versus anticoagulation alone. We'll go a little bit more into the primary outcomes in the ensuing slides. Next slide. To be included in the study, patients had to be age 18 to 80. You had to have evidence of a CT-confirmed acute PE with evidence of right heart strain by dilated RV to LV ratio, elevated cardiac biomarker, and signs of cardiac respiratory distress. I want to just take a moment to highlight this. This was a pretty stringent inclusion criteria. You had to meet two of these three criteria, one being ECG or telemetry confirmed tachycardia greater than 100 beats per minute. You it have signs of either tachypnea or hypoxia, or a sustained low blood pressure, systolic blood pressure less than 110 millimeters of mercury for at least 15 minutes. Patients who were in shock or now class E1, E2 were, of course, excluded from the study. Next slide. So back to the primary composite outcome. This included PE-related mortality, PE recurrence, or cardiorespiratory decompensation or collapse within 7 days of randomization. And at least one of these criteria for cardiorespiratory decompensation had to be met. That's, of course, cardiac arrest, requiring CPR, shock, need for mechanical circulatory support or mechanical ventilation, or a new score, natural early warning score of 9 or greater on 2 consecutive measurements greater than 15 minutes apart. Next slide. This is a grid of the National Early Warning Score. This is a validated scoring system that was actually derived in the United Kingdom and implemented across the UK. It's actually been adopted in other European countries. And you can see these are very objective criteria of cardiac or respiratory distress, signs of respiratory rate elevation, hypoxia, low blood pressure, tachypnea or tachycardia. And you can see here circled, if you have a patient who presents to you with a respiratory rate of 22, their oxygen saturation is 90, they're on 2 liters of oxygen, their systolic blood pressure might be 110 millimeters of mercury, and they're tachycardic, that might get you a new score of 8. And we'll go into a little bit about the different levels of severity based on this National Early Warning Score. Next slide. So these are the randomized groups after screening and randomization. Approximately 273 patients were in the intention to treat arm for ecos versus 271 for anticoagulation alone. Few protocol deviations. Next slide. And here's the study population. These are the patients that we see. Mean age is approximately 58 across the board. Larger proportion of them are men who are white. And their symptoms are commensurate. Next slide, please. Their symptoms are really reflective of who we see. They have symptoms of shortness of breath. If you go forward 1 slide, they have chest pain, a quarter of the patients, syncopes, they have tachycardia, tachypnea. And I'll just highlight here a very important point that the new score was a mean in both groups of 6. And 6, as I showed you in the last grid, really reflects that what we previously called intermediate high-risk population, and Dr. Piazza will go a little bit into the more nuanced categories in the new guideline system. Majority of patients were treated bilaterally in terms of catheter-directed therapy. They received a mean dose of 17 milligrams over 7 hours. I'll highlight that almost 3/4 of patients received therapy within 2 hours of treatment after randomization. Next slide. And you can see here for the primary efficacy outcome, that's the composite of cardiorespiratory decompensation or collapse, PE-related mortality, or PE recurrence again. This favored the ultrasound-assisted catheter-directed thrombolysis arm with a relative risk reduction of 0.39 and a p-value of 0.005. Next slide. And you can see here the breakdown of those patients who met the criteria for decompensation or collapse. If you go forward in this build, you'll see a majority of them had a new score less than 9. And again, 9 was the threshold by which if they met that criteria within 7 days of randomization, they could be treated according to the operator or institution's preference in terms of their impending collapse. Next slide. And this shows just that if you go forward in that pie graph on the right side for the intention to treat patients undergoing rescue therapy, 79% percent of patients met the criteria for cardiorespiratory decompensation as defined. Next slide. Here, it's important to note that in the interventional arm, the hospital length of stay was shorter than those who received anticoagulation alone. Interestingly, there were only 70% of patients in the ECOS arm who were admitted to the ICU. We can go back to that for the discussion. 50% in the anticoagulation arm went to the ICU. That is not surprising to us. But among those patients who were admitted, hospitalized in an ICU, the ICU length of stay was shorter for the catheter-directed thrombolysis arm versus anticoagulation alone. And all of these meant statistical significance. Next slide. I think we'll spend a moment here just to look at these data. Remember the PEITHO slide that I showed you, the original data for tenecteplase versus placebo? You can see here that the pre-specified definitions for major bleeding, ISTH, Gusto at 7 days, at 30 days, no statistical significance between either arm in terms of major bleeding. And most importantly, there's no intracranial hemorrhages that were seen in either group, either ultrasound-assisted catheter-directed thrombolysis or anticoagulation. Next slide. And here are the 30-day outcomes. So all-cause mortality was very low in both arms, 1 to 1.8%. No significant difference in terms of symptomatic recurrence, and SAEs, significant serious adverse events, were low and no different between the two compared to arms. Next slide. So in conclusion from HI-PEITHO, in patients with acute intermediate risk PE, ECOS, ultrasound-assisted catheter-directed thrombolysis, reduced the composite outcome of PE-related mortality, cardiorespiratory decompensation or collapse, or symptomatic PE recurrence within 7 days. There were no significant differences in terms of major bleeding between treatment arms and no intracranial hemorrhage. And as a segue, I think this really marks a pivotal moment in our field, which I'm sure Dr. Rosenfield and others will talk about. This is a landmark trial. Could provide class 1 level of recommendation for this therapy, for this risk category of patients. And I'll be interested to see the other panel members' thoughts. But on behalf of the investigators of the study, executive committee, some of whom are here, and consortium, and most importantly, our patients who are being treated for PE, we'd like to thank you for attending this and for your enthusiasm and engagement. Thank you.
Thank you so much, Michael. So let's get into it. And so we're going to have a bunch of conversations about a lot of different aspects in this trial. And as at the beginning, I would just kind of like to go around the horn, kind of like part of the interruption. And I would like to ask everybody just your brief comment. What surprised you or excites you about this trial? And so why don't we start? Kenny, why don't you go first?
Thanks, Keith, and thanks, Michael, for a great presentation of the trial results and summary of the trial. I think what excites me, if you give me my 30 seconds, is that this is this is a landmark trial, and it's the first ever trial to show really hard differences. We chose hard endpoints here, and it was statistically significant. It was a different model for a trial. So many things that excite me about this trial. I can't even start, but the fact that it was a really dramatic outcome, showing a very significant impact of this therapy of intermediate of advanced therapy for intermediate risk patients. And it's the first of its kind to do that, really, looking at hard outcomes.
Awesome. Greg, surprise, excite, or both?
Both. I think that what surprised me pleasantly is how well HI-PEITHO and the data that it produced fits with the new AHA-ACC guidelines from 2026. The study population that's the focus of HI-PEITHO is exactly the population that the HA guidelines, HACC guidelines really are emphasizing for consideration of advanced therapies. So we're thinking about patients that we used to call intermediate high risk. Now we can be a little bit more granular and point out that these are these patients C3, which are patients with positive biomarkers and an increased RV, who also have some enhanced risk, like the HI-PEITHO study qualified patients to have, and then patients who might have what we call incipient cardiopulmonary failure, patients who are on the edge, maybe normotensive shock, that we now know, these were a lot of HI-PEITHO patients.
Awesome. How about you, Sophia?
Yeah, so I'm overall very excited about really having that answer, to the fundamental question. Because, Ultima came in 2014, then we have the PEITHO in 2015, and all this time a lot has happened. But the question that adding intervention to anticoagulation in this intermediate high-risk category, and now we know in a select population, can change that trajectory or not. So we have that question answered, and that's very exciting. And really the select population, the way the trial is, that enriched criteria, that adds a lot, because not only the intervention, but only to which patient. So that's very exciting. Little surprising to kind of know that 30% of the patients didn't go to the ICU after intervention. Just, as an intensivist, that kind of surprised me a little bit, but I mean, that's a good thing. So those are my two big opinions there.
Perfect. All right. Peter, as the person who enrolled the first patient in the trial in 2021, would it surprise you or excites you about the results?
I'm going excited, Keith. So, it's amazing to think about when we started enrolling in this trial, a lot of people just didn't believe in advanced therapies for PE at all. And now here we are with these results and outcomes. We'll talk about the trial design, and we'll talk about how this trial protected by design patients from death, from being denied a commercially available therapy. And so what we're really looking for is to prevent decompensation. We're looking to see that difference. And we saw it in a really robust way. So, I'm excited for these first days in life after HI-PEITHO, because suddenly we have landmark clinical trial data that shows a robust difference in an RCT done across the world. And when people are making decisions about what to do with patients, both in centers that already had well-developed PERT teams, but maybe even more importantly, in the centers that might now be referring to places or developing their own PERT teams for the first time, we're really going to see a revolution coming out of this. So excited, all excited.
Fantastic. Yeah. And then another distinction, the investigator who enrolled the most patients in the United States, Michael, what excites you or surprises you about the trial?
Keith, I think I'd add on to what Peter and others mentioned. One, I've always said that patients that we treat for PE are sometimes the most vulnerable, the ones that we don't know which direction that they're going to go, right? And we worry about those patients. I think we all have stories of those folks that we think are doing okay. They look a little bit worrisome. I guess in this trial, they would have a news score somewhere between 6 and 8. And what you're trying to change is the trajectory of their disease. And what we're looking for is something a little bit more than a surrogate endpoint. I think many of us believe, yes, having a dilated RV compared to the LV when it looks really sick is not a good thing, but we really needed a hard endpoint. And I think this trial provided that, and that excites me. I think personally, what surprised me was the level of engagement, I would say, in terms of all the three. It's important to highlight here, this was not just an industry-sponsored trial. This was PERT Consortium. This is the University of Mainz as a consortium of academic physician scientists in the space, Boston Scientific as well. So it was really a collective effort throughout the field to move the field forward. And the fact that people had the equipoise to take a sick patient with a news score of 6 or higher and enroll them in the study, that says a lot. And the fact that it does show this level of difference, I think, substantiates perhaps what we were doing in the past years.
Yeah, no, thank you. And we're going to get into all these points in the next, 45 minutes. And Michael Jaff, the other day we were chatting, and kind of what surprises us is that this is a very rigorous trial to have enrolled patients into. And when the trial was being set up, we came up with, when the envelope is open, when somebody is going to get randomized, they needed to be treated within 6 hours. And to then see that 75% of the patients were enrolled within 2 hours, that shows just incredible commitment by really investigators, across the globe. And so we were really excited about that, but surprised, because that could have been an issue for the trial if people, weren't going to play like that for enrollment. So, okay. Let's go back to the beginning, Kenny. I know you're the sage one here. You can give us kind of what was the impetus for doing this trial in the first place? Can you kind of bring us back to that, table in London that we were sitting around in 2019?
You remember it well. It's a great story about the way this trial developed. The scientific genius was really from Stavros Konstantinidis, who can't be on this call, but he was the co-principal investigator with me, and it was a privilege to really have his incredible wealth of knowledge about PE, he's dedicated his life to this. He's the author of the European guidelines, the last 2 European guidelines. He was a co-PI of the HI-PEITHO trial, which has been mentioned here twice. So his vision was that we need to figure out, well, can we get the benefit of PEITHO, as Sophia was saying, the benefit of improving the outcomes without the risk of bleeding? And if we could do that by giving a lower dose of thrombolytic therapy directly into the clot with ultrasound facilitated catheter thrombolysis, then that would work. Or that was the genius. That was the thought. And it was an investigator-driven trial, really. So he actually came up with the protocol, and we came up with the protocol together. We modified it at that table in London and presented it to, at the time, it was BTG who owned ECOS. And they were about to fund it, and then suddenly Boston Scientific bought ECOS. So that turned out to be a godsend, I think, in the long run, because Boston Scientific, a year and a half or so later, decided, with the push of Michael Jaff and many others, and the support of Jeff Mervis and others at the company, to support this trial. And that actually was a godsend. They stuck with it. It was a hard trial to enroll. Imagine your patients who are pretty darn sick, as these are not the patients that were the average intermediate high risk patient. They're average intermediate with an enhanced risk. That we injected these 3 other criteria that really elevated the risk. These are sick patients, and for our investigators, as dedicated as they were, and you're looking at 2 of the very dedicated investigators here, in Peter and Michael, to approach patients and say, look, what has been standard of care has been anticoagulation, but we have this other therapy. Of course, it's been used a ton, but we want to randomize you. That took a lot, and to get it done within 2 hours. But I will say the trial was constructed. We knew we had to have hard endpoints, but we didn't want mortality to be one of them. And frankly, it would have been, unethical almost to. So that's why we set up this unusual trial design. And I'm not sure if you want to talk about that now or get to it later, but it's just briefly. I'll just say at the outset that there hasn't been a trial with PE where you do what we sort of do. Greg, you alluded to this, and Michael, where you make a decision about a patient and then you follow them over time to see, is the decision the right one? And you can pivot after you've made that initial decision to another decision if they deteriorate. This trial had that built into it, and that was novel trial design. So I'll stop at that point. Keith.
Perfect. Thanks, Kenny. Greg, can you tell me, we've heard now more than once that this was just not a regular old industry-sponsored trial, that there was a unique leadership structure both the kind of a tripartite leadership, but also a very active executive committee. Can you kind of take us into kind of that design and how that functioned, in practice over the course of the setting it up and also the trial?
Absolutely. I mean, I think that in order to execute a trial like this, we needed organizations that had complementary skill sets and resources. So from the University of Mainz, it was really experience in this type of trial in the PE space, knowing how hard it is to enroll PE patients into studies. From the PERT Consortium, Ken, Michelle, really having developed such incredible relationships with sites across the US to find sites that are going to be able to make the hard decisions about enrolling patients in trials. I mean, that's not easy. And then with Boston Scientific, an incredible partner, not just from a science aspect, but also from a logistics and planning perspective. Really, all of these put in equal effort to make this happen. And that's what we're looking at right now is the success when three organizations that care deeply about pulmonary embolism and making treatment better put their minds, their hearts, and in many cases their wallets together.
Perfect. Thanks, Greg. And Kenny, let me go back to you. It's interesting, and I know Greg's going to get into this in a little bit. This trial was designed 5 years before the most recent ACC AHA guidelines came out. And in that trial, the writers basically said, we're not going to accept surrogate endpoints anymore for any influence of our recommendations. And so it's almost like the executive committee and steering committee were prescient in that they designed a trial with these hard clinical endpoints. Kenny, can you talk to us about the components? Why were these important? Tell us a little more about these hard clinical endpoints of the trial.
Well, I mean, the obvious ones are the PE-related mortality. That's obvious. Recurrence of PE that's symptomatic and confirmed by PE by CTPA. That's kind of an obvious one. But the hard endpoint that was that we established using the NEWS score predominantly was cardiorespiratory decompensation or collapse. We all know what that means. That's, like I was saying before, as you're following a patient along, treating them with whatever you've treated them, if they then deteriorate, in some way, how do you quantify that? So this was obviously cardiac arrest, resuscitation, signs of shock, ECMO, intubation. These are the hard endpoints, but the NEWS score ended up being the one that really tipped the balance, because most people don't end up getting ECMO after they're in with a high intermediate risk PE, but some people do deteriorate. And it was Eric Klock that came up with the concept, endorsed also by Andrew Sharp, the concept of using the NEWS score, which was, again, very easy to measure. These are things that I think Greg mentioned it earlier, or maybe it was Michael. These are easy things to measure in a CCU or on a floor. They're just respiratory rate and heart rate and blood pressure and so on, basically vital signs that are has been validated. And by using this, we were able to intervene when we saw that a patient was deteriorating and call that an endpoint. That was an endpoint. At that point, when you establish after 24 hours of initial therapy, if the patient deteriorated, then we knew that we were at an endpoint, and we were at an endpoint, and the patient could be then treated with whatever rescue therapy the team decided was best. But the point of this is that these are hard endpoints. They're not soft things like numbers of days in the CCU and things like that, which are important. But this is fundamental to treating patients with PE to make them better.
Perfect. Yeah. And so we saw the results of the composite endpoint. Peter, can you kind of just dig in for a minute about your feeling about why mortality wasn't high in this trial?
Yeah, that's a great and a super, super important point. Especially in cardiology as a field, we get very used to looking at a paper and saying, is there a mortality difference? No, okay. The design of this trial, the implementation of news scores like we talked about, was meant to protect patients against a mortality difference. So the fact that you were reaching an outcome when you hit an objective cardiorespiratory decompensation with the news score, that protects those patients from ever getting to a mortality outcome. And that's extremely important when you think about this as a technology and really how all these trials are going to be designed, because it accomplishes two things. It helps investigators, it helps me, it helps Dr. Young as we're putting patients into these trials to randomize them, because we can say, if you get sick, you've reached an outcome. You're going to swap over in therapies. But then it also gives us the opportunity to look at a very objective outcome of decompensation. This isn't saying I, as an investigator, thought someone was doing poorly, so I swapped them over. This is saying they reached a hard outcome, which it was great at the seminar at ACC having some of our European colleagues on panel, because they were talking about what news scores meant. If you're in Europe, your news score is above 7, you go straight to the ICU. And so that concept of hitting that well-delineated outcome, being protected from mortality, but creating a reproducible study is hugely.
That's awesome. Yeah, thank you.
Peter said it much better than I could. That was beautiful.
I mean, Kenny, no problem. I think it was quite additive. Our goal was to protect patients and certainly not to follow the natural history of a patient with PE who's going to, circle the drain. Greg, let's talk about the enriched patient population that was selected. I think, anybody who's participated or designed a clinical trial really knows how difficult it is to determine a sample size to reach statistical significance. But when enrollment criteria include vital signs, that's certainly something. How did we come up with that enriched patient population, Greg? Tell us a little more about that.
Yeah, I think it was really born out of the recognition that intermediate high risk PE is a really broad and heterogeneous population. And we, I think, knew that if the patient population enrolled wasn't of high enough severity, it was going to be hard to meet the event rate that we expected for the trial. And so picking these enhancement features, actually it's eerie, Keith, when you think about how it foretold what would end up becoming of the AHA-ACC guidelines from 2026 in the clinical categories, where we're now considering respiratory abnormalities. So here we can see the clinical categories from the 2026 guidelines. And for what's pertinent for us is the C category, which is what used to be intermediate risk. And then as we increase in severity and go from C1 to C2 to C3 is where we start to get into the HI-PEITHO population. That's RV that's abnormal and an abnormal biomarker. Respiratory modifier is very similar to the things that we were considering in HI-PEITHO. Next to that is the D category, which these patients with incipient cardiopulmonary failure or normotensive shock, they were buried in the intermediate high risk category and nobody could see them. But now we have given some tools to identify these patients with transient hypotension, patients with elevated lactates. And there were actually quite a few patients in HI-PEITHO that were like that. And I think if we go to the next slide, we can see that when we're thinking about advanced therapies, it's really starting with the C3 category. And certainly the publication of HI-PEITHO actually will encourage us to think about these C3 patients, and then the inclusion of D1 and D2. And we can go to the next slide. And so I think Michael gave us a nice overview of news, and I think Ken put it well. The novelty here, the innovation, is the fact that you're using the news in a serial fashion to detect deterioration, not just as an endpoint, but for a decision about whether we need to do more for these patients. But anybody who had questions about whether we enrolled a soft population, let's go to that next slide. So we look at the next slide. This is a HI-PEITHO patient, okay? A 66-year-old woman, history of rheumatoid arthritis, comes in with sudden onset dyspnea and chest heaviness. She's alert, but found to have tachycardia with a heart rate of 114 beats per minute. Blood pressure is a little soft, 104/60. She's tachypnic, and she's hypoxemic to 92% on room air. They end up evaluating her with a D-dimer that's elevated. Her trope is up, and she gets a CT that shows bilateral main PE with a dilated RV to LV diameter ratio. So the question is, this sounds like a HI-PEITHO patient. How sick is this patient? Is she really sick? And if you hit the next, you can see actually the new score here is 10, and 10 puts this patient into a high risk for an urgent or emergent response. So these were these were patients with significant risk of not doing well. And I think that's what enabled us to have such a successful trial, is we weren't going for easy patients. And that's why every site had to work really hard to enroll these patients, because you needed to, I think Ken put this best, you needed to feel almost uncomfortable enrolling your patient. Ken, you remember saying that you should feel a little uncomfortable enrolling in HI-PEITHO, because if you do, then you have equipoise. Oh yeah, just here, just showing.
Yeah, do you want to speak to this?
Yeah, sure. Showing that the hinge point for the new score really, to start showing deterioration or a high risk of adverse outcomes is 6. And we really went, we required 9, making sure that there wasn't going to be any question about the patients that had to go to rescue therapy or who were called clinical deterioration. Next slide. Yeah, and so here you can see just sort of the patients that met the primary outcome for cardiorespiratory decompensation or collapse criteria. Not subtle. These were big changes in the news criteria, and we really made sure that this was going to be an unassailable part of our decision making.
Yeah, perfect.
Okay.
And I think you did a great job explaining that. Bottom line is we definitely wanted to eliminate investigator bias, right? Like most people are used to that bedside gestalt when they kind of feel that the patient, they want to start and do a therapy and escalate it. And here you needed to have that score of at least 9. And again, 2 of them separated by 15 minutes in order to hit that endpoint. So this was certainly not a softball. So,
Keith, let me just mention that,
sure.
when we had those discussions, there was in the background some noise, but we initially thought 8 would be a reasonable number, and we decided to increase it to 9 because we wanted to make it clear that there would be no question that these patients are sick enough that they hit an endpoint. And that was it was a feature that when we sat around that table in London, it was, no, we're not going to take 8, let's go 9. And we knew it was going to be harder, though, to achieve that endpoint. And what's remarkable is we did. By the way, I don't think this has been mentioned, but we didn't do this in the initial presentation, but the number needed to treat for this trial to stop the cardiorespiratory decompensation is 16, less than 16, which is actually quite remarkable. Most trials, are considered successful if it's a much higher number needed to treat. This is only 16, so it's a pretty impressive result.
Absolutely. All right, Sophia. So now we've talked all about this trial, and tell me now, from the referring physician, pulmonary critical care perspective, is this the data that you and your colleagues were looking for to sort of change the paradigm of PE treatment?
Yeah, thank you. What a great discussion, and I just loved hearing everything again, really. I think, just to be upfront, I think the conversation regarding this intermediate risk, high risk patient population needs to change. And we really need to look at the so-called stability or compensated state in a different way. And I know people have been practicing for 10, 20, 30 years, and they feel like, anticoagulation is the way to go, and that's the end of the talk or discussion about a patient. So that's HI-PEITHO challenges that belief, or that habitual practice, or whatever you can call it. So I think that's the first thing. And I think it's the select patient population is the key here. Yes, it's not like a blanket approach that everybody in intermediate high risk category needs to be intervened upon, but it clearly says that there are patients hiding in that broad spectrum, which AHA kind of helps kind of bring those patient populations a little bit forward as far as the C3, the D1, and the D2, as Greg mentioned. So I think we got to take a look at this patient population differently. Number two, it's very important. I think it increases our confidence when we go to the bedside and have that conversation and offer the intervention, because I've heard it so many times, there's no data, there's no data. But we have data now, and that changed as of last Friday. So I think, and it's robust level 1 data. So I think my peers, my colleagues who don't do interventions themselves, like I said, again, the question a little bit about what you're calling stable or compensated state. Look carefully about this patient population and the patient at hand to see if the criteria are met, and offer and consider and have that conversation, and not just conclude on anticoagulation only, because 61% deterioration prevention, that's huge. Because if you think about it, I remember that graph in Steinmata's data where it says that they're on that graph, and after that is deterioration and death. The goal is to prevent that. You don't want to see that. Mortality is not something, and this is not a trial where it's like salvage. No, you want to prevent and not go that route. And it is easily teased out the patient population that you can intervene upon to change that direction towards clinical improvement and not see that crash or deterioration. That's what I'd say.
Right. Perfect. I'll have one more for you. So we saw Michael presented the incredible safety profile, really low bleeding risk, no different than anticoagulation alone. Do you think that this now puts the nail in the coffin to the referring or the pulmonary critical care community that says, well, we're not going to give lytics or catheter-directed lysis with ECOS because of bleeding? Do you think that kind of puts that to bed?
Not to see intracerebral hemorrhage, that's a big one. PEITHO, we saw that there was direction and tenecteplase help, but the bleeding risk is what stirred us the other way. So I'd say not seeing intracranial hemorrhage is very reassuring, and seeing that there was no difference. But obviously, study was not powered enough to see the difference in bleeding. It was not set up. We'd need maybe 1,500 patients for that, or maybe 3,000, 15 in each arm. But I'd say it's reassuring. And with the patient bleeding risk, I think definitely it eases our discomfort with the risk that we were thinking about before.
Perfect. All right. Michael, let me go to you now. From an interventionalist perspective, you're in a big academic medical center, but you obviously have a lot of surrounding rural hospitals. Talk to me about the meaning of HI-PEITHO and use of ECOS in the practice, and maybe a little bit about the hub and spoke model that I've heard you so eloquently discuss before.
Thanks, Keith. I think, as we all know, many of us practice at centers where we have referrals for patients who are quite far away, living in a sort of underserved, under-accessed area of the country. And where I practice, in particular in northern New England, we have patients from northern Massachusetts suburbs all the way to the Canadian border, many of whom only have access to maybe like a walk-in clinic or a small emergency department. So we are truly a spoken hub model. And the thing that's always bothered me is that when we bring patients to us, there is sort of a system delay in a lot of ways, from the time that they're diagnosed to the time that they reach us. And sometimes it makes me curious about some of the patients we did originally screen who, perhaps were no longer eligible for HI-PEITHO because they graduated. Their new score went from 6 all the way to 10, and then they ended up getting lice before they got to us. But I think if you think of the reflection, as I do, of the complexion of our country, many of our patients do live in rural areas where they're not just down the street or across the street from a large tertiary medical center. And so, to your question, when you think of resources and what is needed to implement a procedure like this, we know for interventionalists like Peter and myself and Kenny on the line, these are safe, now proven to be effective therapies that are very teachable. the ability to disseminate it, I think, will be important because there are hospitals out there with one cath lab or one IR suite. If you have a champion for PE who really wants to take care of their patients and not send them 300 miles away, that might be one thing to think about in the future.
Perfect. And Peter, from your perspective, besides being, at a big health system, I know you sit on the Ascension group that really talks about PE all the time. Kind of, how do you look at this and the results of the trial and what we're offering for patients?
Yeah, it's huge. Our clinical practice all breaks down to the big quaternary centers where we have all of the tools available and we're working to optimize, and then outreach centers that are driving patients in and taking good care of the community. And it's really kind of remarkable to have a big clinical trial that's touching both of those groups to such an extent. I mean, I'm not exaggerating when I say that when this trial started enrolling, one of the main benefits of participating in it was the fact that we're able to include emergency room doctors and pulmonary critical care doctors as our investigators, because they were really challenging us to prove that any of this stuff works in pulmonary embolism. And now we're sitting here with just robust landmark data that shows that it does. And you couple that with the fact that for every hospital that's treating pulmonary embolism with advanced therapies, there's probably 5 to 10 that's not. And when we think about the referral patterns within those networks, it's a very different day when you have randomized control trial data proving a transition away from a cardiac decompensation. I mean, if you go to a hospital that's not doing this stuff, you got to think about where you're sending those patients. Every hospital in America now, I think, has to have a plan for what to do with these intermediate, high-risk pulmonary embolisms, and they really didn't before.
Perfect. I'll throw this one out there before I get to the next topic of guidelines, which is, we hear about the ICU and how sick patients are or aren't that can have a procedure they don't need the ICU. We hear about this all the time. What about a comment about this trial that you saw 50% of the anticoagulation arm going to the ICU, and who wants to take that one?
I'll
Michael,
take that
go
one,
ahead.
Keith, if that's
Yeah.
okay. Just as a side note, I would just highlight that before I came onto this call, I was invited to a journal club by our pulmonary group. A fellow was giving a journal club on HI-PEITHO. So, one of the questions that was posed to me by one of the intensivists, who's incredibly smart, experienced, 30 plus years of experience, very astute, said, what do patients want when they come into the hospital? I think the obvious thing is we all want to live and survive, but they're, fundamentally gets down to 3 things. They want to get better and oftentimes get better quickly. They don't want to stay in the hospital for a long time, and they want to resume their quality of life over time. And, what I said was, quite frankly, this trial probably substantiates at least 2 of those 3 goals right now, meaning we know for ICU length of stay, hospital length of stay favored the catheter-directed arm. Number 2, we did prevent cardiorespiratory distress or collapse. And then number 3, which will be borne out, I think, from the data, which we're all interested to see following these patients out to a year, the quality of life and other secondary, softer endpoints. There's the post-PE syndrome that we see in our practice as an outpatient. Who knows? We'll see what the data shows eventually from that. But I think in my mind, in terms of utilization and from an administrative leadership perspective, we need to rethink the sort of paradigm of, okay, if they receive this catheter-directed therapy, whatever it is, ECOS included, they need to be kind of planted in ICU regardless. And this kind of showed that not everybody needed that, right?
Perfect. And so, this fantastic evidence that we have, Greg, tell me, does this trial have the merit to change guidelines, and kind of give us an inside baseball look at, when could we expect that, if you think it could?
Yeah, I mean, this not only can change guidelines, it should be reflected in guidelines. So when you sit on guideline committees, the question that always comes up, is it a randomized controlled trial? And, was it a clinical outcome? And both of those are checkboxes here. This was a rigorously run trial. with a lot of different innovations, things that are going to influence the way we practice medicine in the PE patient, serial evaluations, use of the news score. And so I think that, yes, this really does have influence on the guidelines. When we're going to hear about a change, I think the ESC guidelines are being written now, so there's a good likelihood of it being reflected there. HAACC guidelines probably won't have an update for at least a little while, because with all these trials coming fast and furious, it can't be that much of a living document where it's updated after every trial that comes out. But I think that there will be an update, but I think this sets the bar for what's going to be required for a high level recommendation from guidelines.
Perfect. And we are getting a couple questions coming in, and I'll just throw this provocative one out. Peter, you want to take this one? There's a lot of catheter treatments out there, right? This trial was with Echos, and certainly we just discussed the fantastic results. Do you think it's fair or appropriate to just apply this and say, well, this applies to mechanical thrombectomy, and what should people do with their practices?
That's a great question. I mean, you're right. So the whole field has exploded, in terms of the interventional options that are available. And ultrasound-assisted catheter-directed thrombolysis and mechanical thrombectomy are two very different therapies. We're talking about a small 6 to 7 French system that's infusing lytic, directly, versus a 26 French sheath that's pulling out tubes, pulling out clots in bulk. And there's differences there. There's differences what happens proximally. There's differences what happens, to the downstream capillary bed. We've got a world expert on VQ and pulmonary flow in Dr. Piazza here. So this, for the first time, we actually have randomized evidence with an objective endpoint saying a technology works. Thank goodness, because we're 14 years into this, without it, which isn't 40 years, but it isn't 2 years either. And we're doing a lot of these techniques and therapies. And so I'm glad that the challenge was taken on to demonstrate, RCT evidence with a hard outcome for the first time. I think a lot of us said if HI-PEITHO didn't work, I don't know if any of this works, and we would all have had to take a deep breath on PE therapies. We now know that this one technology is safe and really effective with a hard outcome, and that's what we know. And there's a challenge out there to other technologies to try to push that same considerations forward.
Perfect. Hey, Ken, I'll ask you as sort of, a founder of PERT, in the absence of guidelines changing yet, what should people do with this evidence and their clinical practice? What would you recommend?
It's really challenging to know exactly how to integrate it into practice, but I do think that what it does is, first thing I want to say is that this is PERT has been all about developing an evidence base and closing the evidence gap. We're 25 years behind MI and stroke, and we need to accelerate rapidly to try to close that evidence gap so we know what to do with individual patients. I think that PERT meetings should still happen. This doesn't mean, this data from this trial is just the beginning of evidence development. I mean, there are other trials that are out there that are actually important for evidence development, and some of the thrombectomy trials that have been done are important. The trials with other catheter-directed lysis, they're all important. But this one is really the granddad so far, or the first one that's really sort of because of the hard endpoints that we talked about, and the large number of patients and the rigor of the trial. But I still think that it's just a little bit of evidence, and we need to still figure out, when you have a patient that comes in, where do they go, where do they stratify along the guidelines? The new guideline that Greg and Michael were a part of. I'm not sure, Sophia and Peter, you might have also been, but Greg, as was mentioned, is a little bit of the architect of some of the stratification. And I think, when a patient comes in, you're gonna still wonder, okay, where does this patient fit in that strata, and what is the best therapy. I still think those decisions will have to be made with a group decision,
Perfect.
multidisciplinary experts.
Awesome. Thanks. All right. And before we have our closing points, I'll throw this one out here, really provocative here. As we discussed, 75% of the investigators enrolled patients within 2 hours of randomization. I know a lot of people there in the PE treatment world, shudder to think this, but are we now coming up with a new time to treatment? Let me get Sophia's perspective as the pulmonary critical care physician who's standing over that patient. And then I'll take, Michael as an interventionalist. Why don't you give me your perspective? Sophia.
That's a tough one there to, do we have a time to intervene for PE? I would love the 2-hour intervention time. I really don't know, honestly, how practical it is. We all have to maybe look at, I'd say, take inventories of your own practice and resource available, and see where maybe it needs to be reproduced. Can it be done repeatedly in this time frame? There's availability, so many logistics involved in here. I'm not sure if I can say that, but I'd like to come up with this collective effort of figuring out, as I would say, the PERT consortium and other industry and scientific community, to figure out, when we have this patient population, a select patient what is the right time to intervene, whether it's 2, 3, 4 hours. Definitely not maybe 12 hours, but which we sometimes end up doing and taking that much time considering. But it does raise a question. I don't think I have an answer. I think more work needs to be done, and ideal time needs to be established for PE.
Perfect. I know most of the interventionalists were probably cringing at that question, but that came up in the chat. So, and I guess I'll ask this, Michael. So if you are looking at a C3, D1, D2 patient, maybe representative of a HI-PEITHO patient, what is your thought in terms of time to treatment?
Yeah, I think it's a great question, Keith, and I'm glad I was given a little time to think about it. But I would reframe it as, in follow-up to Sophia, time to recognition, of how sick the patient is. And I think of all the patients we screen, I think of the people who didn't make it to us, who then got lysed or transitioned or got worse or didn't get transferred at all. I do think this highlights the fact that these are sick patients, and that if you're able to prevent their decline or collapse, that's the important time point. And I think, obviously I'm very interested in future analyses and other trials in the space, like Kenny mentioned, that's going to give us more insight into this. But yeah, in the interventional world, we've thought MI time is muscle. I think for us here, early recognition, maybe people should be looking at the news score more closely and carefully. That may determine how they treat the patient.
Perfect. Well, wonderful. Well, I was tasked to keep us on time. It is a minute before 8. I want to thank a fantastic panel with really a very engaging conversation. We are so excited about HI-PEITHO, spreading the word of the results. I think we should all be very proud of this trial. The results are fantastic. I think we are answering questions on how do we treat these sick patients. I think watchful waiting for these sick patients is no longer acceptable. And I want to thank all of you, as well as the PERT Consortium for hosting this webinar. And I think there's a survey to take, but thank you, and I hope you have a wonderful evening. Thanks.